Welcome to my channel, Physio Guruton. So today we are going to talk about the humerus. So my name is Hardik Parab, and today we'll be talking about the humerus. This bone is the longest bone of your upper limb. Okay, and this is very important bone because as a physio, we will deal with many of the cases which are getting fracture around the humerus or fracture in the humerus. So that's why it is one of the important bone in anatomy when you have to consider for the upper limb. So the first thing in humerus, if we discuss, so humerus, it's a bone of arm, which is the longest upper limb bone, and it has a different parts that you get upper end, you get lower end, and then shaft. So in that way, this is forming your humerus. So humerus is having upper end, then lower end, and in between you get a long shaft. So because this is the longest bone of the upper limb, and it has the longest shaft. So we can see here that this humerus, the upper end, is connecting with the scapula and it is making a shoulder joint, while the lower end will be connecting with the radius and ulna, will be helping you to form your elbow joint. So there are different parts. The upper end is connecting and forming the shoulder joint, lower end is forming the elbow joint. The shaft is making the length of the arm. Okay. Now we'll see the side determination, how you'll come to know that which side of this bone it is. So right now, which one I'm holding, okay, I'm holding it in this way, okay. So you can see here, the upper end, the spherical one is the upper end. It should be always up. It is connecting to with your scapula, so it is proximal end, upper end or proximal end, which is spherical in shape. The lower end is flattened one, okay. It is expanded and flattened one. Now this head, the upper end, which is having the head of the humerus, it is directed medially, upward and backward. So if you see, it is going medially. It should be medially. It should not be in this way. Suppose if it is of right side, it should not go outside. It should be, well, now this is my right side. It should not go in this way. It should be medially. It should be upward and it should be backward. Okay. So in that way, it is forming your upper end, while the here you get an impression. Okay, in this area you will getting an impression. यहाँ पे impression होता है, which is called as lesser tubercle and greater tubercle. So the lesser tubercle is project from front of upper end and limited laterally by the bicipital tube. So that impression, this impression which is going down, is called as bicipital groove. So you can see here, this is an impression. यहाँ पे you'll be getting up lesser tubercle. Here you will getting greater tubercle. So this is an impression, okay, and that impression medially you will get lesser tubercle, which is projecting from front of the upper end in this way. This one is of my right side of the humerus because the head is projecting medially, the lower end, which is flattened one, upper end is spherical one. And if I want to if I want to explain, I'm going to hold it in this way. This is the best way to explain it. So where I'm holding it, it is a medial epicondyle. So by holding the medial epicondyle, you can explain the whole thing. So this is of your right side of the humerus. Okay, this is of your right side of the humerus. So now we'll see the upper end. Upper end will be having a head which is a spherical in shape, जो spherical होता है, गोल होता है. Okay, so it's spherical in shape, and the head is directed medially, upward and backward. This is connected with the glenoid cavity of the scapula. Scapula we had already seen in the previous video. You can see it on the channel. So in that, the scapula, which is having a glenoid cavity, which is directed laterally, it is connected with the head of the humerus, which is directed medially. And in that way, it is making your shoulder joint. So after this head, the next part which comes over here is your anatomical neck. So the anatomical neck of the humerus, it's a line that differentiating or separating the head from the rest of the upper end. So here you get anatomical neck. This is your anatomical neck. The anatomical neck is differentiating. So in picture, you can see the yellow color. One is the anatomical neck, which is different, which is separating the head of the humerus from the rest part of the upper end. So here you get anatomical neck. Okay, there are conditions where the anatomical neck is getting fractured. Then you get lesser tubercle as I shown you here. So here you get bicipital groove or intertubercular sulcus. It has two names, bicipital groove or intertubercular sulcus. Medial to that, you get lesser tubercle. Now here very important muscle of rotator cuff subscapularis is inserted. Lateral to this groove, in between, you get a groove. Lateral to that groove, you get greater tubercle, and where your the three important rotator cuff muscles, sit muscle, supraspinatus, infraspinatus, and teres minor, will be inserted over here. In the upper end, these two main structure is your lesser tubercle, intertubercle sulcus, and greater tubercle. They are present. After that, we had seen that till now we had seen the head, anatomical neck, lesser tubercle, greater tubercle, intertubercular sulcus, or bicipital groove. The next one is surgical neck. So what is surgical neck? Surgical neck is present over here, which is separating the head of the humerus from the shaft. Okay, so here you'll be getting a surgical neck. There are situations where the surgical neck is also getting fracture, and morphological neck is 0.5 centimeter above the surgical neck. So over here, this is your surgical neck. 0.5 centimeter above that, you'll be getting another neck called as morphological neck. So in this way, this is making your upper end of the humerus. So you get head of the humerus, you get anatomical neck, lesser tubercle, greater tubercle, intertubercular sulcus, surgical neck, and above that, you'll be getting morphological neck. Then you get the shaft. Now we'll be talking about the shaft of the humerus. So the middle portion of the humerus bone, which is connecting the head of the humerus from the till to the lower end of the humerus. And so this portion is shaft. Shaft of the humerus is rounded in the upper part, while in the lower part it is getting flattened. Okay, so it gets flat and it's getting triangle in shape. So, but in the upper part it is rounded. It has three border and three surfaces. So first we'll see the border. It has an anterior border, it has a lateral border, okay, and it has a medial border. So the anterior border is present over here. Anterior border is upper one third of the anterior border. It's starting from the lateral lip of the intertubercular sulcus. So you get intertubercular sulcus over here. It has medial lip and lateral lip. So this is your medial lip. This is your lateral lip. So you can see here, this one is your medial lip and lateral lip. In between that, you get the sulcus. From this lateral lip, your anterior border is started. So in the upper one third, upper two third, upper one third, this anterior border is present. Then in the middle part, it becomes more prominent and it forms a deltoid tuberosity anterior margin where the deltoid muscle is inserted. Lower half, this gets smoother one. The anterior border is gets smoother one and rounded. Okay. Then you get lateral border. Lateral border is more prominent in the lower part. Okay, and it is making the lateral supracondylar ridge. Lateral supracondylar ridge is giving origin to the lateral uh, epicondyle, where your common extensor of your forearm is originated from there. The another one is medial border. So medial border, this one is the medial border. You can see here, this is your medial border, which is extended up to the medial epicondyle ridge, or medial supracondylar ridge, and it is connected with the medial epicondyle. So here is your medial epicondyle. As I told you, we have to hold it in this way when you are explaining the humerus in exam. So this medial epicondyle is giving attachment to the or origin to the common flexor muscles of the forearm. So we saw three border, entry border, lateral border, and medial border. Now the surfaces. So first you get anterolateral surface, then anteromedial surface, and posterior surface. The anterolateral surface is present between the anterior border and lateral border. So here you get anterolateral surface. Anteromedial surface present between the anterior border and medial border. So this one is your anteromedial surface. And if I turn it posteriorly, you get the whole posterior surface. In this way, it has a three surfaces. In anterolateral surface, it is having one groove, V-shaped groove, which is present over here. It is called as deltoid tuberosity. So here you get V-shaped groove called as deltoid tuberosity. Okay, and that is connecting your deltoid muscle. Then behind this deltoid tuberosity, another groove is present, which is called as radial groove. Radial groove is providing space for radial nerve. So in any situation where the shaft of the humerus is getting fractured, this radial nerve can get injured or can get compressed at the radial groove area. So here you get a radial groove. Okay, it is present over here. Just behind the deltoid tuberosity, you get a radial groove. Then in anterior medial surface, it is present with, as I told you, it is present between the anterior border and medial border. And there are few muscles. Then it has a nutrient foramen, which is the artery which is supplying the humerus bone, is entering from the anterior medial surface. And then on the posterior surface is another important one because it has an important structure named radial groove. So this is your posterior surface. Here you get radial groove. Radial groove is like extending in this way. So this, as I told you earlier, the radial nerve is present in this radial groove. And even from here, you can palpate the radial groove. So any kind of damage to the radial groove can cause damage to the radial nerve. And in that case, patient may develop wrist drop, where the common extensors of your forearm, wrist, finger will be paralyzed. So after this, we'll move on. So right now we had seen the borders and surface, as I told you. But there are three borders: anterior, lateral, and medial. And there are three surfaces: anterior medial, anterolateral, and posterior surface. Okay. Now the next is your lower end. Lower end is quite complex, but here it is very easy. So it has two types of structure: articular part and non-articular part. The articular part will be making connection with radius and ulna to form elbow joint, while the non-articular part doesn't have any connection with the other bone. Okay, but as a structure wise, you need to know about each and every structure. So the first thing, what you see over here in diagram, if you see, this is a medial epicondyle. Just beside that, you'll get a trochlea, and beside that, you get a capitulum. Okay, this is the anterior portion. So this is your medial epicondyle. Here you get trochlea, and here you get capitulum. The capitulum is connecting with the head of the radius and is making humeroradial joint, a radial part of the elbow complex. The trochlea is connecting with the trochlear notch of the ulna and is making humero-ulnar joint, which is the medial component of the elbow complex. In this way, these are two articular structure. The one is present over here, the other is present over here. This one is your capitulum, the lateral one, outer side is your capitulum, inner side is your trochlea. Trochlea is connecting with the ulna, forming humero-ulnar joint, and capitulum is connected with the radius and forming humeroradial joint. So these are the articular structure. Non-articular structure, you get medial epicondyle, which is quite more larger one or extended one, medial epicondyle, and this is continuing from the medial supracondylar ridge. Supracondylar, above the condyle, the ridge which is present is called as supracondylar ridge, and it is on medial side, that's why it is medial supracondylar ridge, is making the medial epicondyle. Then lateral supracondylar ridge, which is smaller than the medial epicondyle. It is also continuation of the lateral supracondylar ridge. Then coronoid fossa. Coronoid fossa, which is just above your trochlea. On the medial side, you get a trochlea. So this is your coronoid fossa. Above the trochlea, you get a coronoid fossa, and above the capitulum, you will get a radial fossa. So this radial fossa will be providing a space to radial head to rest over there. Posteriorly, you get olecranon fossa. This is olecranon fossa, which is providing resting to the ulnar head, and it is again an important structure to provide rest to the olecranon process of the ulna. So in this way, we saw the lower end of the humerus. In lower end of the humerus, we had seen the medial epicondyte, then your trochlea, capitulum, lateral epicondyle, lateral supracondylar ridge, medial supracondylar ridge, then radial fossa, coronoid fossa, and olecranon fossa. Now, the next important part in any osteology topic will be the muscle attachment. So, the muscle attachment, if you see in the upper part, you have, as I told you, subscapularis, which is inserted over the lesser tubercle, then supraspinatus, which is inserted over the supraspinatus, infraspinatus, and teres minor are inserted on the greater tubercle, which is present over here. Okay, so it has three impression, upper, middle, and lower impression, which is providing attachment to this thick muscle, supraspinatus, infraspinatus, teres minor. Then you have pectoralis major. Pectoralis major, latissimus dorsi and teres major. To remember that, you can remember in form of lady between two major. The pectoralis major is inserted over the lateral lip of the intertubercle sulcus. Teres major is inserted over the medial lip of the intertubercle sulcus, and in between that, you will get a latissimus dorsi. So in this way, it is giving attachment to the pectoralis major, latissimus dorsi, and teres major, that is lady between two major. So in the upper part, you get subscapularis on the lesser tubercle, supraspinatus, infraspinatus, and teres minor on the greater tubercle. And over the bicipital groove, you have three muscle attachment. They all three are inserted over there. So they are your pectoralis major, latissimus dorsi, and teres major. So that is lady between two major. Then after that, we are moving on the next portion in the shaft. So the content of the intertubercle sulcus, it has a long head of biceps. Here, the another structure which is present is long head of biceps, an ascending branch of the anterior circumflex artery. Then over the deltoid tuberosity, which is there on the anterolateral border, anterolateral surface, it is giving insertion to the deltoid muscle. Then you have corycobrachialis, which is originated from tip of the carotid process and inserting over the medial side of the medial border or medial part of the shaft of the humerus. Okay. Then you have brachialis, which is originated from the lower half of the anterior border of the humerus. So you get brachialis. Then you have brachioradialis, extensa carpi radialis longus. These two are originated from the lateral supracondylar ridge, okay, and lateral epicondyle. So from there they are getting originated. So brachioradialis is in upper two-thirds of the lateral supracondylar ridge and extracarpi radialis longus in the lower one-third of the lateral supracondylar. So above part is having, this one is for the brachioradialis and here is for the uh, extensor carpi radialis longus. Then you have pronator teres. Pronator teres is arising from the lower one-third of the medial supracondylar ridge. In this lower one-third of the medial supracondylar ridge is giving attachment to the pronator teres. So deltoid over the deltoid tuberosity, corycobrachialis is inserted over the medial surface. Then you have brachialis, brachioradialis, extensor, so brachioradialis over here, extensor carpi radialis longus here, and on this side you get pronator teres origin. So all these are the originated from here. Corycobrachialis is and deltoid, which are inserted into the humerus. Rest, the other four muscles are originated from there. Then you have the next is the common site, uh, the other muscles which are originated from here are the triceps, then the superficial flexor muscles. Or superficial flexor muscles are your, as I told you, flexor carpi radialis, flexor carpi ulnaris, palmaris longus, and flexor digitorum superficialis. They are originated from the medial epicondyle. From lateral epicondyle, you will get origin of the extensor muscles. They are your extensor carpi radialis brevis, extensor carpi ulnaris, and extensor digitorum. Uh, and on the posterior aspect, you get an attachment origin of the triceps. So tricep it has three heads. The long head is originated from the infraglenoid tubercle, which is there on the glenoid cavity, in the lower part of the glenoid cavity, on the scapula. While the other two head, that is medial head and lateral head, they are originated from the posterior surface. Above the radial groove, you will get lateral head, and below the radial groove, you will get medial head. In that way, they are getting originated. Then you have another important muscle, which is an anconius. Anconius is again and strong. It's an extensor of the elbow joint. So it is originated from the posterior surface of the lateral epicondyle. So on the lateral epicondyle, this is the posterior surface of the lateral epicondyle. So from here, you get origin of the anconius. Then the three nerves, very important one, the axillary, radial, and ulnar nerve. They have a close approximation with the humerus. The axillary nerve is surrounding your head of the humerus, neck of the humerus. Radial nerve is superficially present, and it is also connected with the connected in the sense they are lying beside the radial groove, within the radial groove. And then ulnar nerve, which is present over the medial epicondyle, okay, behind the medial epicondyle. So these are the three common areas where these three nerves can get injured. Now we'll see the clinical anatomy. So the commonest site of the fracture, if you see, it is in the surgical neck. Okay, you get the fracture of the surgical neck. Then mid shaft, maybe the shaft of the humerus where the radial groove involvement is very common. That area, this shaft area, is very commonly to get fractured. And then you have supracondylar fracture, okay, which is again very common fracture seen in the uh, children, but even in adults also it is quite common. Supracondylar fracture, it can give rise to Walkman ischemic contraction. Now, this is again a very important complication of fracture. So, any fracture which is surrounding the elbow or humerus fracture, they can get a Walkman ischemic contracture, where the blood supply to the distal forearm muscles or forearm muscles can get affected. Forearm, and because of that, the patient will have necrotic changes in those muscles and can give rise to this kind of deformity, which is called as Walkman ischemic contraction. Then, if you want to know whether your elbow is normal or not, whether there is any dislocation, subluxation, or any kind of fracture, you need to see the three bony points to find out whether you're having normal elbow, which is your lateral epicondyle, middle epicondyle, and olecranon process. So for that, you got to see it in this way. Now here you get middle epicondyle, here you get lateral epicondyle, and posteriorly you get olecranon process. Normally it will be approximately in one line. But if you find an olecranon process is quite up or below that line, that indicates that something is wrong with the elbow joint, which can be seen in case of fracture or dislocation. Then the humerus, it has a very poor blood supply at the junction of upper and middle third. So any kind of fracture which is there in the upper and middle one third, they are quite prone to develop non-union because of the poor blood supply. The head of the humerus can get dislocated. You can see in the first diagram. So, from its normal space, from its glenoid cavity, it may be the most commonest dislocation is inferior dislocation. Even there are certain cases where you get anterior dislocation or posterior dislocation. That way, the head of the humeral dislocation is very common. So here we came at the end of the humerus. So as we know that a humerus is very important bone for your upper limb, the longest bone. It has three parts, upper end, lower end, and shaft. Upper end is having an important structure like surgical neck, anatomical neck, lesser tubercle, greater tubercle, and intertubercle sulcus. Then you get shaft. In shaft, you get deltoid tuberosity and radial groove. Then lower end, you get middle supracondylar ridge, lateral supracondylar ridge, medial and lateral epicondyle, capitulum trochlea, and olecranon fossa. So all these structures are very, very important, and you get an attachment. And among these attachment, the insertion of the scapular muscle, that is your supraspinatus, infraspinatus, teres minor, subscapularis, then pectoral region muscle, pectoralis major. Another scapular muscle will be teres major, and latissimus dorsi. All these are inserted in the upper part. You'll get another insertion of deltoid in the shaft. Then triceps is getting originated from there. Right? Triceps mainly two head, lateral and medial, because the long head is originated from the infragranular tubercle of the scapula. Then coracobrachialis is also inserted over the medial side of the shaft. Brachialis, brachioradialis, extensor carpi radialis, longus. They are originated from the shaft. Then in the lower end, the common extensor origin, common flexor origin of the forearm muscle from lateral epicondyle and middle epicondyle. Origin is will be happening over there. So in that way, we had seen the whole of an important part of your humerus. Uh, you can refer it from the Pedichaurus, yeah, where it is given very nicely. Even you can refer it from the atlas, anatomy atlas, to have a proper picturization, proper idea. So I'll suggest you to read from the textbook. That will be more beneficial for you. And at the end, we had seen the clinical anatomy. So I hope that you are clear with the topic humerus. Okay. If you get proper idea about any of the topic from the videos, kindly do like and subscribe. Okay, because that helps me, that motivates me to do further work in a proper way. Okay, so once again, thanks a lot and all the best.